Assalamu alaikum wa rahmatullah. Thank you, Mr. Chairman and Lady Chairman. I'm going to present to you what's missing of diabetes guidelines with focus on risk stratification. First, I present a case scenario, followed by risk stratification for this case by current guidelines, excluding AASD, because there is a much to work, or much work is going now to improve the accuracy of these guidelines. Then the missing rule of microvascular complication in risk stratification with regional variation, and the need of strong evidence and multidisciplinary approach. What about the associated condition and a hint on drugs? This is our case. Ahmed, 66-year-old man on pension, diabetic type 2 since 7 years, hypertensive since 10 years, is currently on DPP-4 inhibitor, metformin, SGLT2 inhibitor combination, ARB and diuretic for hypertension, and his blood pressure is controlled. His A1C is 7.5. His estimated GFR is 63 milli per minute, been 1.73 square meter. As for other risks, his LDL cholesterol is within target on statin ezetimibe combination. He has no history suggestive of macrovascular disease. ECG is normal. No history suggestive of hypoglycemia. He has clinical evidence of diabetic neuropathy. Fundus revealed non-proliferative diabetic retinopathy and has evidence of microalbuminuria. TSH is normal, and is asking whether he will fast or not. The DAR guidance, year 2021, is an excellent document. Even if we disagree with some opinions on it, still it is an excellent document. The most of the guidance available for the management of diabetes during Ramadan, as said the authors of this document, represent expert opinion rather than medical evidence. This is a great problem because we lack a solid medical evidence. This is the risk score developed by DAR Alliance. As you see, this patient has almost zero score. He, as you see in here, type 2 diabetes, 0 point, duration of diabetes less than 10 years, 0 point, no history of hypoglycemia, 0 point, A1C is 7.5, 1 point. He is not in insulin, he's just on other therapy, not including sulfonylurea and insulin, 0 point. The self-monitoring of blood glucose may not be available for him, has no acute complication, has no evidence of macrovascular disease. The estimated GFR lie within the 0 point. Again, of course, the pregnancy excluded. Has no impaired cognitive function. His age is 65 or 6, something like this. Is not a physical labor. Previous experience with Ramadan is okay, no problem. Fasting hours nowadays is less than 16 hours. So this patient, by the current guidance, should or must fast. Has low risk for fasting. What about AASD and ADA guidance? The very high risk group, he's not included by any way in the very high risk group. The high risk group, he has no significant microvascular or macrovascular complication. Here come a problem with the guidance of the AASD and ADA. The term is significant. You may say this is significant microvascular combination. Someone say, no, this is not significant microvascular combination, complication. So the precise or the precision in this document of AASD and ADA is not completely precise. The rest is excluded. Otherwise, he could be considered as moderate risk or low risk according to the guidance of ADA and AASD. One more problem of this guidance, it does not consider the clustering of condition in one patient. A patient with A1C from 8 to 10 with significant microvascular complication, and he is living alone with insulin or sulfonylurea, has some comorbid condition, should not definitely put in this class. He should move to the very high risk group. So the lack of appreciation of clustering of risk factors in one patient is not found in the ADA and AASD definition. The important, or the best, or the value of DAR is that it can let you to individualize the risk for each individual patient. But on the other hand, the cardiologist may have another opinion. Any diabetic patient, according to the European Society of Cardiology, any other patient, any patient with diabetes mellitus and established cardiovascular disease, this is not the condition, has a target organ damage, albuminuria, for example, is this patient, 3 or more risk factors present in this patient, he's a very high risk patient. How to solve this problem? The evidence was being a very risk patient, cardiovascular patient, can we let him to fast or not? This is the value of evaluation of microvascular disease. Let's see. In nephropathy in type 2 diabetes study, in a cohort of 742 type 2 patients, albuminuria has a relevant prognostic factor on cardiovascular morbidity and mortality, pronounced when GFR is normal. This is very important. Second, in a review by Rosenson, involved 25 studies and included 54 or more than 54,000 patients. Diabetic retinopathy was associated with 1.5-fold increase in cardiovascular event, and albuminuria and reduced estimated GFR or GFR was associated with 2-fold increase in cardiovascular presence, and in the presence of more than one microvascular complication, the risk is accentuated. Moreover, in a meta-analysis by Z et al., data showed that patients with type 2 diabetes, those with proliferative retinopathy or diabetic macular edema, had an increased risk of incident, very important, incident cardiovascular disease and cardiovascular events compared with those with non-proliferative diabetic retinopathy or neuroretinopathy. In another study, Targer reported that both non-proliferative diabetic retinopathy and proliferative laser-treated retinopathy are associated with an increased risk of incident cardiovascular events in type 2 diabetic patients without any significant sex difference. Also, Lhamdi reported that in type 2 patients with diabetic peripheral neuropathy, they have a higher risk of association with cardiovascular disease than those without peripheral neuropathy. So, if we want to identify which patient who could fast, we can use this microvascular complication as indicator for patient with higher risk for cardiovascular event while fasting. We come now to regional factors. Climate, you know, we have hot weather. The average temperature in Egypt in summer months is 40. It may increase to 45 or even 50 in some areas. Economic factors. I'd like to say that we are in the low middle rate of income in the World Bank evaluation. So the luxury of air conditioning, the availability of self-monitoring systems or apparatuses, the availability of much more safer drugs is not present for this patient. We have a higher number of manual workers, so the manual working should be included as a risk factor for our patient. It is a little bit underestimated for the patient, for the DAR guidance, and it is overestimated a little bit in the AASD ADA guidance. This is the employment distribution in Egypt in 2020. We have 23% of people are working in the agricultural sector, and the construction sector 14%, and manufacturing 13%. All of these jobs may include hard manual work. So the manual work has to be implemented in the physical exercises has to be implemented in the guidance. The need of more evidence. This is very important. Back to DAR, which again I stress that DAR is an excellent document. This is the data represented for the evaluation of patients with chronic kidney disease and whether they should fast or not. These are the studies showing worsening outcomes. The first one includes only 15 patients with chronic kidney disease. 20% of cases were diabetic, so it's a very small study. In another study, the number of 68% had insulin-required diabetes. They reported that the patient developed acute renal failure. In another study involved 106 patients, only 52 patients fasting. The most important that this patient have an increased risk of cardiovascular event. Finally, there's a case with 65% included stage 3 or higher chronic kidney disease. Only 38% has diabetes. Those patients those studies showed stable outcomes. Okay, the number of patients 31 from 1 to 5 chronic kidney disease. Only 60% were diabetic, and a 57 patient, only 31 patient fasted, and a 94% on another study was 94%. Only 45 patients fasted, only 32% were diabetic. The number is 39 patients with chronic kidney disease, stage 3 or higher. What I want to say is the level of evidence presented in the study was not enough to conclude a solid evidence in such a serious matter like fasting Ramadan or not. So I'll take you to another example. This is not related to diabetes, but related to cardiovascular disease. This is a recent document, Fasting and Cardiovascular Disease, published in Heart Journal this year. I would like to discuss with you the stable angina. Patient with a stable angina was classified as moderate to low risk patient. Depending on what? Depending on two studies, Khafagi and Musafi. I'll take you to the two studies. The first study of Khafagi, only 56 patients were studied. Angina was presented as 45 patients. Diabetes was presented in 20% patient. The study focused on a subjective evidence, whether the patient how does he feel during Ramadan, and after Ramadan there is no report. So as you see, the evidence here is weak. When they look to the high sensitive CRP or serum leptin, this is a surrogate end marker. أنا خلاص قربت أخلص. This is a surrogate end marker. The study limitation, they say that they have a small number. A larger sample is needed. However, they stated the answer to the cardiac patient question about fasting during Ramadan has been found, which I doubt. The decision to fast should be individualized at any patient according to clinical status. This is another study by Musafi, only included 66 patients who fast. The patient inclusion criteria does not include diabetes mellitus requiring insulin or uncontrolled diabetes. The light of their results, they stated that it would not be necessary to prevent patients with chronic heart disease from Ramadan fasting if they are not complicated by significant heart failure, renal failure, gout, or they do not use insulin for control. I'll let you, with our chairman, to judge, is this evidence is enough to give a guidance, or we still, as I think, need much more evidence to take a strong decision. Finally, I would like to say that we need multidisciplinary approach involving more than one specialty, cardiology, nephrology, neurology, and other systems if needed to put a good guidance for the patient. We should look to associated condition, not any associated conditions, the conditions that may be worsened by the complication of fasting in diabetic patient. Like, for example, Dr. Ines discussed the hypoglycemia and arrhythmia, hypoglycemia and history of convulsion, dehydration and patient taking anticoagulant, dehydration with patient or increased thrombosis with patient with DVT or liable to develop DVT. And finally, drugs which we use in treatment of our patient is very important. There is some drug interaction. I'll give you an example. In an elderly patient with on SGLT2 inhibitor and diuretic, he may be liable to dehydration, more severe dehydration than expected. And finally, thank you.